Hello, my name is Brent Leininger, and I'm a clinical researcher here at the University of Minnesota. I'm also one of the co-investigators on the PACBAC trial. The findings from our trial, which included 1,000 patients, were recently published in the Journal of the American Medical Association, or JAMA, and JAMA Internal Medicine. And I'm here to tell you a little bit about the trial, including why it's important, what we did, what we found, and what it means. So let me start with why this trial is important. Low back pain is one of the leading causes of disability worldwide, and it's also a major challenge to the healthcare system here in the United States. Often, acute episodes progress into persistent, impactful chronic pain, and this is especially true for patients with elevated risk factors. Now, currently, most treatments focus primarily on symptom reduction, and they fail to address the broader biological, psychological, and social factors that drive chronic pain. We conducted the PACBAC trial to determine the most effective way to prevent this progression. So let's talk a little bit about what we did. We conducted this randomized trial enrolling 1,000 adults who had either acute or subacute low back pain and were at moderate to high risk for developing chronic pain. We divided participants into 4 treatment groups, with each receiving 8 weeks of interventions. Participants received either guideline-based medical care, spinal manipulation therapy, a clinician-supported biopsychosocial self-management, or a combination of the spinal manipulation and self-management. Physical therapists and chiropractors delivered the spinal manipulation and the supported biopsychosocial self-management, while advanced practice clinicians and physicians provided the medical care, which primarily involved NSAIDs and muscle relaxants. We then followed participants' progress over a 1-year period. So let's talk a little bit about what we found. When we looked at overall impact of low back pain at the end of the year, we found that clinician-supported self-management resulted in a significantly lower back pain impact score compared to medical care. Spinal manipulation therapy did not differ significantly from medical care, and adding it to the self-management program provided no additional benefit. The supported self-management groups also experienced a small but statistically significant reduction in their average disability over the year compared to medical care, but there were no differences between groups in average pain intensity over the year. We also conducted responder analyses to provide a better understanding of how to interpret these group differences. 2/3 of participants in the supported self-management group achieved a substantial reduction in their disability, compared to about half in the medical care group. In addition, at the end of the year, self-management group had approximately 10% fewer individuals reporting chronic pain that frequently interfered with their daily activities, as well as the use of medications and healthcare interventions for their pain. Our mediation analyses revealed that the success of the supported self-management was largely driven by improvements in psychosocial factors, such as increased self-efficacy and reduced fear of movement. So now let's talk about what this all means. Ultimately, these findings are clinically relevant and highlight the need to shift how we approach back pain in the United States. Clinician-supported biopsychosocial self-management is more effective than guideline-based medical care at reducing long-term disability and preventing impactful chronic low back pain. We think the findings from our trial are likely to inform updates of national clinical guidelines on the treatment of low back pain. And by helping patients build the capability and motivation to manage their own pain, we can address their needs from a more holistic perspective and reduce both the personal and societal burden of chronic low back pain. Thank you.